all I know about it. So with that, I'd like to talk to you this morning about bundle payments. So I think everybody's been hearing about this topic for the last several years. I mean, we've heard, I think, extensively about how bundle payments are going to change our practices, not just in joint replacement, but perhaps going forward across all the subspecialties. And so we thought this was a good time to share with you our experience and kind of our evolution and our journey through the bundle payment experience, which we started around 2013. And so we're going to try and share with you that experience. We have a great crew, Chris Pell, Jeremy Gillen, Jill Erickson, Zach Watney, all of who have been very, very involved in the process along the way. So I'm going to give just a few introductory remarks, and then we're going to make this a group experience and let them share with you individual aspects of our program. So why are we here? Why this issue of bundled payments to begin with? Well, this is really the take-home message. If you look at healthcare spending as a percentage of GDP, we're off the charts at 17.1% compared to most of the westernized countries in Europe. You can see the huge disparity, and that gap continues to grow. If you look at per capita national healthcare spending in the U.S., $9,000, $9,500 a person for a total expenditure of $3 trillion in 2014, and the total national percent of GDP is now around, at least in 2014, at 17.5%. So that number continues to rise. If you look just at joint replacement, the Medicare costs are estimated to be $7 billion for just the hospital portion alone. If you add in the physician side, you add in ECFs, everything else, it probably approaches close to 10 to 12 billion. And one of the things that's really critical in driving the bundled payment initiative is the per episode cost for a joint replacement is highly variable. So on the low end, we can see costs of around $16,000. On the high end, $70,000. Huge spectrum of cost disparity across the country. And what goes along with this is variation in quality as well. And so from a Medicare perspective, from a CMS perspective, this is where there's a great savings opportunity. So Medicare payment innovation has created a couple of different programs to try and drive bundle payments, at least initially, in joint replacement. And the two programs that have been introduced are called Bbci and CJR. So Bbci was introduced in 2013 by CMS, and CJR was introduced in April of 2016. And there's slight differences. I don't really think it's important that you remember all of these differences. We are involved in Bbci. It's really a non-hospital centric model where physicians can participate, ECFs can participate. Over 2,000 organizations participating now. Both programs disrupt the fee-for-service business model. You can see the Bbci program is voluntary, the CJR program is mandatory in certain geographic regions across the U.S. 2,000 programs in Bbci now, 789 hospitals in CJR. This is just a map of the United States with participating programs in the Bbci program. So again, over 2,000 programs. You can see our region circled there in red. So we are involved in Bbci, Salt Lake Regional, and then one of our local extended care facilities is involved in Bbci. But you can see how extensive this program is already in the United States. And going forward, the vast majority of joint replacement will be paid in this manner. Again, not important to know the exact specifics, but there are basically within Bbci 4 different models. Most of the large academic institutions across the country have signed up for Model 2, which basically just means that we are talking about care for the patient from 3 days pre-op, including the hospital inpatient stay, the MD services, everything that happens as an inpatient, and then everything that happens after the hospital stay for a period of 90 days. So that's Model 2. Model 2 includes everything that happens to the patient 3 days before admission, all the way until 90 days after their surgery. So if the patient has a heart attack, goes to the emergency room, gets cath, that expenditure is counted against our overall cost. Now, all of these programs use retrospective bundling. Retrospective bundling is something that a a lot of times I think is not well understood. How does it work? Well, this is how it works. A claim from a hospital triggers a bundle. A patient is flagged by CMS. Any patient having surgery within that hospital, regardless of the provider, is included in that claim. All providers bill Medicare as normal, so that's what's not, I think, typically understood. And CMS pays all the providers as normal. And then retrospectively, what has been paid out is reconciled against the so-called target price. And we're going to talk a little bit more about the target price, how that's calculated and what that means. But basically, if you've done your care processes in a way that saved money, you get some money back. If you spent more than CMS has paid you, then you are at risk to give money back to CMS. So what's included in this target price? This is a slide from NYU. We're going to talk a little bit more about NYU as well because they've been a big player in the area of bundled payments. So the target price, what's included is, again, everything 72 hours before admission, all the services during the acute period of stay, any services during the first 90 days after the operation. So that is what determines the target price. And that target price is for participating institutions determined by the average cost in a three-year period that CMS has looked at prior to beginning the bundle. So for us, it was from 2009 to 2012. I think is that right? 2009 to 2012. So they looked at all of our primary joint replacements, said, here's what you guys on average spent. That's your target price. Now, NYU has been a very early adopter of the Bbci program. They've probably been the lead academic orthopedic surgery program studying their experience with Bbci and bundled payments. And just a little background, this program is led by a good friend of mine named Pci Payments, who was recruited from Leahy Clinic in Boston to come to NYU to run their joint replacement program. At the time he came in 2010, 2011, they have over 30 orthopedic surgeons, subspecialty trained in joint replacement. And so they had 30 guys doing things 30 different ways, all over the map, costs, quality, all over the map. His job was to standardize it and get them involved in the bundled payment program. And you can see just some brief statistics from their early experience. The bottom line is by standardizing their care, enrolling in the bundled payment program, they improve their quality, they improve substantially their cost, they improve the percentage of patients going home. And so they have now published several articles that outline a very positive experience, including money going back to docs because they've saved money in the overall care process, and including increased quality. So here's our very early experience with Bbci. We started to negotiate with the hospital in 2014. We had a slight delay negotiating about some of the resources that we felt we needed, which put us into July of 2015 when we went at risk in the Bbci program. In October 2015, we brought on a care coordination company called TAB that Jeremy's and Jill are going to talk to you a little bit about. And then in 2016, we started at least to have a verbal agreement about gain sharing with the hospital. Now, just coincidentally, NYU also has come up with these 7 pillars for success in bundled payments, and in many ways it mirrors our early experience. And so the things that we're going to focus on with you today are just 4 of the things that they have identified as 7 pillars for success, including care coordination, data, the robust data collection system, control of the post-discharge costs, and then identifying and aligning stakeholders. So that's what we're going to focus on for the rest of the time. This is kind of a brief outline. Jill's going to cover care redesign. Jeremy's going to cover TAP Health. Chris is going to share with you some of our early results. And then Zach from the hospital side is going to talk a little bit about finances.
Good morning, everyone. So I'm Jill Erickson, physician assistant with the joint team, and recently I've been promoted, or I elected to take a more leadership role in bundle payments. So Dr. Saltzman gave us a gift of Dory Trimble in November of 2014, and we were told that she was going to help us evaluate our culture of post-acute care. and figure out why it is that we're using so many skilled nursing facilities and how we can make moves to change that in order to see if we could accept being in a bundle with Medicare. Some of the things she found out was that we really needed to change the discussion about post-acute care. We were basically just letting a patient come in for a joint replacement. The case managers in the hospital were figuring out what the patient should do afterwards. We weren't specific to educating the patients about whether they should go home or to a skilled nursing facility or even rehabs. Later we found out rehabs are very expensive, so we've shifted these things all through this redesign of our care. At the time we were doing what we were calling joint camp, and we decided to change that to more of an educational session. I'll go into what that involves. We also made 9 videos that you can find on our website about coaching the patient and their care coach on how to get home and not necessarily need a skilled nursing facility, because most of our patients are coming from home. We think that they can get home. There's just some interesting culture here in Utah that women don't want to ask for help. They think this is kind of like a vacation for them, so they want to go for the maximal allowable that Medicare will let them stay for, sometimes 3-4 weeks. So what Dory did for us is she was able to meet with all of the different players that formed our interdisciplinary team, including pain management folks under the anesthesia department and our block team, and meeting with case management, seeing what we could do to integrate a more proactive role, trying to meet with patients or talk to patients preoperatively about what their plan could be afterwards, rather than just waiting for them to become an inpatient. So the goals of care redesign when you're entering a bundle payment are generally to grab the low-hanging fruit and just say, okay, we're just going to cut out SNFs. Some places around the valley are doing that, and I worry that you would end up with more ED visits and more readmissions. So we took a more active role in getting the patient engaged and having every patient get a care coach, which is usually their significant other or a family member. If they're an elderly widow, then we ask them to actually involve their children or their sister. We've been able to improve our protocols and pathways and then track data, but the main thing I'm going to go over is how we were able to engage the caregivers and get the patient active in their own care. I just want to highlight some other necessary investments that we had to make. Erica is our pre-service case manager, and she's a nurse that is half ours and half case management. She still reports to the case management department, but she calls all of our patients a week before, and at least a week before, and tries to determine their social barriers, their physical barriers, how they're functioning, what their social structure is, and whether or not we can shoot for getting them home. We've also become more available in clinic to allow any issues at home to be seen in clinic rather than ERs. We've added Laura Wood on the floor to be a more consistent person with discharges. Hope that's been helpful to the residents. And we've needed to improve our immediate access to data, because the Medicare reports come out retrospectively and they wouldn't really help redesign our care. So Jeremy's going to go into that. I just want to point out that it takes a village. We added Erica, who's a nurse, but we have 3 nurses that work with each of the 3 surgeons and 5 medical assistants, 2 of which mostly are making these phone calls that we'll tell you about to try to reach out to the patient before they have a problem. In the redesign of Joint Camp to become Joint Academy, we now hold it twice a month. We're getting at least 12 patients, and then we've strongly encouraged, not mandated, but strongly encouraged they bring a care coach so that they know what's going on too. And the point of Joint Academy is to prepare the patients home ahead of time and prepare the care coach for how they can help when the patient does go home. We don't really talk about whether or not to go to a skilled nursing facility. Almost every session it comes up by someone, and then we talk about all the different ways that we're going to educate them through the written materials, this class, being available, calling them multiple times so that they can actually get home. And that usually does the trick. Patients are usually comfortable. We've been able to get our rate of discharge from a skilled nursing facility at about 40% down to 15 to 20% just in this past year. We now hold Joint Academy at the Wellness Center, and we're starting to record it so that when we don't have someone attending in person, they'll be able to watch and still get the full experience in the education process. As soon as we started Joint Academy and changed the conversation, we were able to get people going home at a higher rate. We've also added providers on call, so myself, Laura, Kristen, and the fellows for the year are rotating through a one-week call schedule. So the resident on call gets a call on joint patient, and they forward the call on to us so that we can try to deal with the problem, either observe the issue overnight, bring it into clinic the next day, or if necessary, you can still go to the emergency room. We're not going to block them from doing that. We just want to offer them enough resources so that if it's really just a red wound, that they're not having fevers, they're not feeling sick, we could watch that, see it in clinic the next day, or send a picture. So I just want to point out the nurses on the bottom have been available for days when we're in surgery, but they're now seeing some urgent appointments the next day. That's it for me.
So as we entered into the bundle, it became pretty clear to us that we would need to be able to track our patients in a new way. We need to get real-time data that was pretty accurate on all of our patients, and it needed to be better data than what we were getting out of Epic. I mean, we needed to be able to track ED visits, readmission rates, complication rates, and we need to be able to see it not only for our own institution, but if the patient was seen at an outside ER, went into an outside hospital, was diagnosed with DVT, we would need to know that on an individual basis as well as a collective basis for our entire cohort. And it was pretty clear that that was not going to happen using Epic or our standard EMR. And so we also needed to see if our Joint Academy attendance was there and if it was having any sort of impact on the patient's outcomes. And we needed this data to be real time. And so as we realized this wasn't going to happen with Epic, we started looking outside of Epic. We started looking into the other centers across the country with guys that we knew that were doing this and asking them how they do this and what systems were they using. And this led us into this arena of care navigation tools, which none of us were really well versed in until we entered into this. And starting with the Academy back in 2015, we went to that meeting and we started meeting with these care navigation tool companies. So we met with a variety of them to try to see what was out there and what already existed. And we found that there were really, the vast majority were sort of application-based systems. They were either a smartphone-based app or a tablet or computer-based app with which the patient would interact with the application on a scheduled basis and then send information to the provider as to how they were doing, and if they had a complication, if they had any issues. And it became pretty clear to us that, I mean, this is our patient population, and I've asked several of my patients to take a picture of their wound over the phone, and there's dead silence on the phone. They have no idea how to either take a picture or then how to text that picture. So the thought of having our patients having an interactive application and then send us the information really just wasn't what we were looking for. We found one company in Tab Health that was doing it a completely different way. Rather than asking the patient to reach out to us, they were reaching out to the patients on a proactive basis. And it wasn't so much a patient-facing application, but rather a provider-facing application that then they, asked the patients to see how they're doing. And it was pretty profound. We met with this company, and I remember sitting in our little conference with them and their people on their team, and they were showing us data from a center that was already using their application. And they were showing us real-time readmission rates, ED visit rates, complication rates for all hospitals involved. So it was one center that had a main institution, but they were saying, this patient went into an ER and 2 states away, and they were able to know that right away. And I was absolutely blown away, and sort of raised my hand saying, I'm going to ask a stupid question, but how in the world do you pull that off? And they just, they said, look, we don't have an app or we don't have some fancy database. What we do is we actually just call our patients and ask them how they're doing. And it was like, one of those light bulb moments, like, wow, that's profound. But the reality is that change has really impacted the way we care for our patients.
To our patients, I think it feels so much better. They feel like we care about them rather than we're giving them yet another application to log into or another iPad to look at. They get a call from us on a regular basis, and my patients really like it. This is Tab's little circle of care. It's a marketing slide, but really we use this on the entire continuum of the episode. So it starts when we first interact with the patient in clinic and when we sign them up for surgery, and we use it all the way through the end of the bundle or in that 90-day period. It's not just the Epic or the EMR that they interface with them when they're in our facility, but we're gathering data on them from the time we meet them till the time we're done with their episode. And Tab's goal is that it continues on in further episodes in the patient's overall health. We don't necessarily do that right now, but that would be the goal. And so this is our timeline as we've interacted with Tab. We met with them at the Academy meeting in 2015, like I said. And the beautiful thing about Tab is they were already experienced at doing this in the bundle with joint replacement centers that were in the joint replacement bundle. And so their expertise we were able to really leverage, and it made it a much quicker process for us to become live and set this up for our center. And so we signed a contract with them in July of that year, which was right when we entered the bundle. And within several months, we were live with them, where we were able to track our patients real time, which has been really helpful for us. And so this is kind of patient-level data that we're able to capture, again, real time, and it's rather accurate. And Dr. Pell's going to go over that data and show you, what we're able to gather. But this is what we set up, and we're able to get all of this data through Tab. And again, it's not through some fancy database. It's not through, gathering all the electronic records in the Valley. But it's simply by calling our patients and asking them, how are you doing? And it seems profound, but it actually works. And so these are the calls we make to our patients. We call them whether they're at home or at a skilled nursing facility. If they're at a facility, we call and talk to the nurse at the facility. But it's a 24-hour call, a 1-week call, and then a 30, 60, and 90-day call. And we're also seeing them in clinic at 2 weeks and 6 weeks. And so we're interfacing with our patients quite a bit more, which takes manpower, and we started trying to make all these calls ourselves with our 2 MAs making the calls, and we quickly learned that was not going to happen. And so Tab Link, which is sort of a service that Tab provides, it's basically a big call center. They make the calls for us at 30, 60, and 90 days. We've got to make that investment. If we then transition to doing it ourselves in the future, we're going to have to invest in more manpower. But the calls are quite helpful to us. It gives us good data, and it helps us to really avoid ER visits and avoid complications. This is what the Tab Connect interface looks like to our MAs when they're making the calls. This is a patient, Dr. Peters, that recently had surgery. But you can see that the patient was signed up for surgery. They were given a joint class or a joint academy reminder call. They then attended joint class. You can see that they attended with one of their coaches. They then got a pre-op call. They went to surgery. They were admitted. They were discharged. It tells us where they were discharged to. And then it's at the top, it shows there's a 24-hour call coming up, a 7-day call coming up, the visits that they have with us, and then the 30, 60, 90-day calls will show up. And at each of those calls, each of those interfaces with the patient, if there's a complication or an issue, that complication gets logged in Tab and in Epic. And so we're now gathering data real time on our patients. And the goal would be to transition this to Epic, to a single interface, single sign-on type system. Epic does have a patient or care navigation platform. It's called Healthy Planet. But the problem is Healthy Planet has no experience in this arena. And if we were to try to develop Healthy Planet to do what Tab is doing for us now, it would have taken a long time. We've been working on it over the last 6 months. We have something that's close, and we're starting to pilot that. I think the goal would be that we then integrate what we have with Tab into Epic, and we'll probably get there. We're not quite there yet, but the strengths have been that we've learned from Tab, we've invested with that, and I think in the future we'll transition to Epic. And so from that, we go to Pelt and move forward on data.
So I think the real thing that Jeremy highlighted was the change in the paradigm with Tab, which was to contact patients proactively instead of listening to our patients reactively, which is how we used to provide care. And the thing that was nice about Tab is they had these set up time frames, 24, 48 hours, 7 days, at time points that were deemed critical in the post-operative care of a patient, where they often were having issues that could lead to readmissions or ER visits. And so they had scripts already kind of developed to answer commonly asked questions and really sort of proactively help a patient instead of reactively listen once they show up at an emergency room. So the clinical stuff we've already been working on here for a long time. We've all been listening to VDO talks. We've all been doing the work on our various value projects in every division. Joint replacement, we were starting this in 2013 with VDO, working on cost and quality things. Our baseline cost shown on the black line, decreasing costs, improving perfect care indices or quality as a surrogate metric there. And so in some ways, maybe we were already hurting ourselves because as Dr. Peters mentioned, we're using our historical average as our baseline, our target pricing point. It's on how well we were performing historically. So the fact that we'd already started reducing costs, slightly hurts our target price, but it's what we're all here to do, to improve our quality and decrease our costs. So that was stuff that we were already familiar with and comfortable with as care pathway improvement initiatives. However, our focus with VDO has primarily been in the inpatient stay. That's where we see our patients, that's where we feel like we have the most power to make change in both the care processes that we're implementing as well as the cost factors. So what we did differently with BPCI is we got this new focus on the 90-day episode, which is a very different way of thinking. And the reason is because this Model 2 focuses on those 3 days before and 90 days after the patient's surgery. And it turns out there's a large aspect of care or cost that goes into the 90 days after the surgery. In fact, it can be more than the actual cost of the surgery and inpatient stay. We've been working on various things like regional anesthesia. We know from multiple databases as well as sort of national best practices that spinal anesthetics have lower complication rates as far as blood clots, lower bleeding rates, lower transfusion rates, and improved early mobility and discharge. And so it's always been a little bit of an issue for us with anesthesia here at the university for reasons that are varied. Some of it has to do with the variability in the staff that we get in the operating room. It's not a consistent staffing mechanism that they have here. And it's also a mentality and a sort of a status quo thing, I think, that general and spinal are equivalent, but we know that that's not the case. So we've been working with them to try to improve that. So we kind of had a reversal of a 60-40 to a 40-60 differential, and we're still trying to improve that further. Lower readmission rates have been seen from patients that go home versus go to SNFs. And this is a little bit of a contentious point, especially if you talk to SNF people, because they'll say, well, you send your sicker patients with more comorbidities to the SNFs as opposed to the patients that are younger, more active, and therefore able to go home, and therefore also less likely to have complications. So we wanted to look into that, and I'll show you a slide in just a minute that shows why this is still an important factor. So not only does a SNF cost money, because you're paying someone to take care of your patient, but we also see that they have higher readmission rates and complication rates. So the TAB reports is something that Jeremy said, in addition to our proactive reaching out to our patients, we get real-time data. So in the first year, we looked at about 1,200 patients. The last 3 months, we've had an improvement to 87% discharge to home and 13 to SNF. The average length of stay is a concerning point in the SNFs because it can range from 2 weeks up to almost 40 days in some cases. Medicare actually will pay for a patient to stay in a SNF for 31 days, and it turns out if you look, a lot of patients will stay for 31 days as a result. They're benefited by keeping the patient there. They get paid to have a patient in their facility. And by the time they're there for 2 or 3 weeks, they're not really doing anything for them. They're just sitting there making money on them. So that's a concern, right? If we do have a patient that has to go to a SNF, we need to start focusing on that. How long do they stay at the SNF as well? And so that's where having control and stakeholders that have buy-in to your program are going to be important. We've improved our Joint Academy attendance. Our successful call rate is about 48%. We're still working to improve. You can see on-time calls, 24 to 40 hours at 62%. 7 to 10 days at 61%, and now the 30, 60, 90 days we're doing by tab link, and an email survey option to reach out is going to continue to improve that, we hope. Very few of them are closed as unsuccessful, 154, and others are too late or no longer necessary because we kind of have lapsed past it. Even though we're making all these phone calls, not everybody answers their phone, it turns out. So improving other mechanisms to reach out to our patients is a way to get at that.
So the TAB people are just doing those 30, 60, 90 days, and we're doing internally the other ones?
Correct.
So they actually have a higher success rate than we do that?
Yeah, and the further out you get, the more,
Well, healthy people.
Yeah, exactly. So they're finally home and they're not dealing with going to the doctor all the time and stuff. So our surgeon data, we get to look at our ER visits, average readmissions, sort of in real time. This is the kind of touches and calls you can see as we started the program, and now the number of patients that we're doing, and you can see how every little area of patient care can be monitored and tracked with data here with these calls. It's a little bit of a busy slide. Sorry, Dr. Burks. He's not even watching. So here's our total number of calls, 10,000 attempts, various people that are doing it, success escalations. These are the things that we have our MAs kind of move up to either the registered nurse or one of the providers because they have some level of concern. So it's not very common that we have a major problem that needs to be addressed, but when we do have them, we're trying to get them to come to clinic. Most commonly, you can see 19 go to USC. 5 escalations went from the MA just said, sounds like you have a problem, that needs to go to the emergency room. And so it's the minority that need to do that, but it is an important factor there. We get to see what our complications are now, the top ones being things that are not that surprising: falls, hematomas, infections or wound problems, blood clots, dislocation of the hip being rare. But now, we didn't used to have this kind of information. A lot of us that are doing our value projects get VDO data because that's what we've got here at the university now. What we do not have is the data of what's actually happening outside of these walls at the university. And most of us here at the university take care of patients that are from not just here in Salt Lake City. Their ER visits are going to be either at St. Mark's or down in Juab or Moab or up in Montana or something like that. And you don't know what your readmission and ER visit rates are like or what the problems that they're being readmitted actually are. BPCI gives us data that's outside of our walls because it's CMS data, so they can see across all providers, all hospitals, because of the single payer system that it is. But with this, we're looking at not just our CMS patients, this is all of our patients. And so with TAV, because we are calling them instead of waiting to get some data reported back to us, we can have more information about things. So our complication rates are relatively low. We've done other care pathway changes and using more aspirin for DVT prophylaxis, rare PEs, and then more discharges to home. This is the slide, this is the poster we're presenting at AUKUS in a couple of weeks. We've talked about PT pathways before. I've given that presentation. This one is about our preoperative education and expectation management of telling patients to go home instead of to SNFs and what the effect and impact of that can be. We've shown a decrease in our SNF utilization, 34% down to 14%. Our 30-day readmissions and our 90-day reoperation rates have gone down dramatically, as shown in the bar graphs. And then what's most important is, as I was trying to mention earlier, discharge to SNF, is that an independent risk factor for a complication? Or is it a factor of patients with more comorbidities go to SNFs and therefore they're more likely to have complications because they're sicker people? Well, we did a multivariable linear analysis. We tried to look at the various comorbidities that could be confounding and then also look at patients that didn't have any of the comorbidities that went to SNFs. The independent risk factor is going to a SNF is a higher risk for complications. And so this is a quality concern, right? So we talked about cost. It's an expensive place to go, but it's a quality factor as well. So when we talk to patients, we don't want to be just saying, well, we're trying to save money so this hospital can be rich. What we want to be able to tell a patient is we want you to have an excellent outcome. And we have data that supports that. Patients that go home can have a better outcome because they're at lower risk for complications. I tell my patients it's kind of like having a puppy that you cuddle too much that drives the puppy crazy. Going to a SNF is like getting cuddled too much. You have too many caregivers, too many people trying to love you. They want to look at your wound. The next nurse every 6 hours rips off the bandage. They draw their little black pin around the wound because it's red. Redness is a sign of healing as well. So anyways, it's just too many people trying to do too good of a thing for patients, I think. Comorbidities is a big deal, so we looked at that. These are the major hospital conditions that allow people to get a DRG 469, which is a higher level of reimbursement from Medicare. But you can see these people are either very sick or dying or have a major complication in the hospital, which you will be winding up paying for if they have that in order to get to a DRG 469. So despite the fact that they have this risk stratification process in BPCI, it's very poor. And so the things that we think are important in surgical outcomes, and not even all of them are listed here, but nicotine dependence, morbid obesity, renal disease, hemophilia, things like that, those are actually still considered healthy patients under CMS's DRG system, so they're still in DRG 470. This is the really interesting stuff we get from Medicare, is that this graph is showing the difference between before we started and now at our utilization of SNFs. That's what the green areas are here. Red is readmissions, yellow is home health care. These lower bars stay pretty constant the whole way across the episode of any patient. Each one of these lines is a different patient, how much it costs for their care. You can see patients that don't get any other services, right, have the lowest cost. This is hospital, and this little bar right here, that's the provider, Profi. So the hospital makes a lot of money, the provider gets a little bit. But look at this, I mean, people that go to SNFs, the cost basically doubles their entire overall 90-day episode total cost. So that half of their actual expenditure is in the 90 days after they left the hospital. So it's pretty impressive. And then the shift in where we're able to send more patients home just takes that graph and puts way more people down the lower half of that. And there's that first 30 days, and then the 30 to 60 days, and then the 60 to 90 days where costs are going. You can see it decreases the further away from surgery patients get. But the cost can be really high for patients going into clinics. We've been able to reduce it by 30, 25, and 15% just by the efforts to get patients home and decreasing complications. And so if we take out the inpatient facility costs, this is the kind of average expenditures you might see in the care of a patient after the hospitalization. So just to put it into perspective, the average hospital cost for their surgery is about $21,000 or so, even though we moved it. If they go to an inpatient rehab, their overall cost is going to be much higher than the actual cost of having the surgery, $35,000 for the 90 days of care. The problem with all of this is that this is a race to the bottom. So Zach's going to talk about this a little bit, how they recalculate every time that you do something. So as we get better, they keep asking us to take less money. We get reimbursed less. 2% reduction just for enrollment. After the first year, they reduce it another 2%. So it's a race to the bottom. As we get better, and we have better outcomes and lower costs, they're going to keep asking us to decrease our target price, so our point continues to move to a lower and lower point. So at some point it is a race to the bottom, and we don't know where that's going to end, and this may not pan out to be successful going forward or profitable for us to continue to stay involved with. But right now, we're showing significant changes in our cost curve, which is a very exciting thing. It's the first time in healthcare in the United States where the cost curve is starting to go down. And we're being involved in that has been pretty exciting for us. And so far, it's been financially rewarding to the institution. And so Zach's going to talk about the financial side of that real quick.
Hey, Chris.
Yeah.
So where does your tab data get stored? Like if it's not talking to Epic?
It's in tab, so it's a duplicate system currently, which is why they want us to bring everything into Epic Healthy Planet. But Epic Healthy Planet doesn't have any of the stuff that the tab does currently. They try to build it to replicate it. Yeah, and that's why the MAs are kind of they're working in two different environments currently. So all the data is in tab. Really the great thing is also, like Jill has a question about what was our readmission rate last week, or did anybody have a DVT this month? I mean, she has somebody on the phone, and in seconds we have data, which, if anything you've done in VDO or Epic, I mean, it takes a couple of weeks to get that kind of information. It's really, really nice.
All right, good morning. Can you hear me right there? Okay. So, my name is Zach Bodney. I'm in the Payer Relations and Contracting Department. There's a couple of things I want to mention before I go into this. Number one, this group over here and their colleagues are the brains and brawn of all of this. I guess I'm just kind of the ligaments, kind of just thrown in there and help connect some things together. The other two things are, this is not going to stop. And it's been mentioned specifically and alluded to with CMS, and this is my first slide is, these payment bundles, alternative payment models, it's the long-term play of CMS. So this will be continually coming out. Commercial payers are getting more and more interested in this space. And so if you haven't heard about this here to date, or if you're more interested, there's several resources to go look at this. So it's going to continue to go forward, and patience is very much required, and I'll show you why. So CMS, we've been kind of delved down into the weeds. I'm going to back up just a little bit, if I may. So CMS, via the Affordable Care Act, started this new program or department called Centers for Medicaid and Medicare Innovation, CMMI. They received $10 billion to do alternative payment model testing from fiscal year 2011 to 2019. So again, you'll see continually coming out from CMS new payment models, and their priorities are, as these last points show, testing new payment and service delivery models, evaluating results, and then yet again engaging in a broader range of stakeholders to develop additional models. So really, they want to test whatever models they can to help save them money. So what are they testing? In short, everything. On their site, there are 75 different programs or models or iterations of their programs they're working on. Some of those include the pioneer accountable care organizations. There's a new wave called the next gen accountable care organizations that are coming out. Medicare shared savings plans, these two comprehensive primary care plans, but of course, also bundles. And I won't belabor this, but we have the CJR, there's an oncology care model, there are new episode payment models, so cardiovascular payment models are coming out here shortly. They'll be announced early next year. They start July. And then, of course, the bundle payment care initiative, Bbci, we have up here. So, specifically Bbci payments, CMS determines the target price, and as mentioned before, we have data. They choose 2009, 2012, that's your baseline period, and then you're measured against that period. So they take that price and then they negotiate it down. They take off 2%, saying we're hoping you're going to save us at least 2%. We're going to take that off. They then further adjust it due to national trends in costs and wage adjustments. So it can go up or down. And then they just measure how you do. So they take your adjusted target price. They subtract the number of payments, so the amount of payments they paid you. And if it's positive, then you can actually earn an incentive if you do well. If it's negative, the hospital, as we're signed up with, the hospital is the awardee, is what it's called. We actually owe them money. So luckily that hasn't been the case. We're doing very well, again, thanks to the team over here. So within the payment model, obviously a lot of work is done via these gentlemen over here and Jill and their team. And so what we can do, what CMS allows us to do is to share some money with that group via what's called gain sharing. And so we have agreements set up with the 4 physicians that were up there before. Bbci is no longer here, so really it's 3 now that we can gain share with. The CMS does put caps on that. So they say you can share only up to 50% of their professional Part B Medicare payments, and those payments have to be subject to assumed quality performance. We have some quality measures established to kind of vet that money through before it goes to. So this is the patients I mentioned earlier, where patients is required. So we have, again, in 2015 is when we started, Q3, this is the calendar year. We started in the first bundle, our first quarter in the bundles. There are several quarters in which the bundles continue or the episodes continue, the claims run out. And then in Q2, so in April this year, we received information then, spreadsheet saying this is how much you made or lost as part of this program. We made money, luckily, and I'll show you the amounts here in a moment. But they then say there's an asterisk next to that saying we're going to come back to you 3 more times until those numbers are finalized. So we won't know how we did for Q3 of 2015, so July to September 15, until the first quarter of 2017. So that's when we know our numbers are final, and that's when the hospital and the department have agreed to, then we actually pass the gain sharing monies through. In the meantime, it just sits in a bank account in Bermuda somewhere, getting high interest rates. So we just have it sitting there, just waiting for us to go. So again, these are not complete for 18 months. This is not an anomaly. This is true with a lot of these programs. And it'll be true with a lot of commercial payers as well. We're talking to them, different groups around the country, and all this, most of it's done retrospective, not the prospective payments that we have. It's all retrospective, just to make sure they can tie out all their claims and all the expenses associated with these episodes of care. So again, how have we done? Here are the numbers. So we have Q3 of 15 and Q4 of 15. So a couple different pieces of information here. What I want to highlight though is this shows these are percent below the target price that we were for each of these individual DRGs for these quarters. So you can see, I mean, not only did we start off doing quite well, but we're actually doing even better than when we started. So all these care processes, refinements, system refinements that have taken place, we're seeing the benefits of that by going even below that target price. That again is going to be continually adjusted downward. So we're going to see this target price set at a fixed rate. It's going to flow downward, but we're still doing quite well. So overall, over $450,000 in system payments. A lot of systems, Bbci, something wasn't mentioned, there are 48 different episodes that hospitals can choose from within Bbci. That's kind of the umbrella system. We've selected one. This is the only program that they're actually saving money in. So CMS has these 47 other episodes, and they just released some information saying they're really not saving money. In fact, they're losing money on some of these. And there are various reasons for that, but within, this is an area, they have CJR, the mandatory bundle. You'll see more and more of these programs coming out, specifically as it relates to jewelry. So one thing, within any of these bundles, there's as mentioned before, there's 4 different models within Bbci. We're in model 2, but there are various iterations within that. You can do 6 different ways to do gain sharing. There are 3 different risk tracks you can take, so they have all these different flavors for each of these bundles. Within it, recently, CMS asked, or participants asked, if they could evaluate and look at removing fractures from the total cost of care, or taking all of the episodes that have fractures in them and separate those from the episodes that do not have fractures in them and have separate prices for those. And so we went through, we evaluated that to see whether or not we want to basically have 4 separate target prices. DRG 469 with and without fractures, and 470 with and without fractures, or if we want to keep those all bundled together. And what we decided to do, we decided to keep fractures in to the overall target, and because we're benefiting from a high fracture rate, high fracture cost, while we were in our baseline period. So here you can see, here's our baseline period, in 2009 to 2012, with this bump in fracture rates. And what that does for our overall target is that brings our overall target up. So we can actually earn more money by just taking care of all these patients the same way we have due process improvement, taking care of them, trying to reduce expenditures. And we will actually earn more in terms of incentive dollars because we have these high fracture rates. So we decided to keep that in. This gives you an idea. You've seen these kind of colored bars before. This is only the fracture episode, and this is for 3/4 of care. That line is where our target is. So you can see within fractures, if you're just looking at fracture cases alone, we are losing some money on these, and as you can see, a lot of that is the SNF charges. But if you go to the non-fracture for the same time frame, that bar is raised up, and so there are quite a few cases. Anything under that bar, anything under that line is where we're actually we're earning incentive dollars for taking care of these patients in the cheapest way, or I should say the most effective way possible, which higher quality reduces cost. So with that, again, Bbci and bundling in general, that's all. It's here. It's going to stay, and it's probably best to sort of learn as much about it as you can, because it's going to come out in multiple flavors over the next couple of years.
Thank you, Zach. Happy to take questions for 5 minutes or so.
So clearly, you guys do really well compared to the rest of the country. Just looking at those numbers compared to the numbers you showed at the beginning. I recognize that the federal government gets a little bogged down in some things, but I can't imagine that it is cheaper for them to just set these prices by areas and by history of an individual center, when to move somebody to another center, even if it's moving them across the country, is still a lot cheaper than the kind of differentials we're looking at here. Is there any sort of talk about that happening? I know that happens with some companies where they contract the specific center to ship all their joint replacements to one center. But is CMS talking about that kind of thing at all, or not?
No, but CJR is the mandatory program, and it's based on regions. And so you're being compared to your competing hospitals in your surrounding region. We have one to the north in Ogden, all the way up through Logan and Brigham. There's one to the south that includes everything in Provo down to Juab County. And those things are going to create regional competition because there will, by default, be people that win and lose in that region because they're being compared to each other, not to themselves. So I believe that that's going to be the first iteration of CMS's regional centers of excellence being created, is because the losers are going to stop doing it. The hospital in Timpanogos is going to say, well, I'm not going to keep doing joints when Ogden is beating us and we're having to pay money to do joint replacements here because we don't do enough of them, we're not good enough, or whatever it is. So CJR, I think, is going to create some regional centers of excellence.
Yeah, I think what's, not written down, but that's their intention, is to drive the creation of centers of excellence that can do this operation, in a very streamlined, high quality, low cost methodology. Travis?
So you guys have done an amazing job doing this. My only question is, when we start, if we have to implement this sort of system across all subspecialties within what years, it seems like, at least by listening to your talk, there's a huge amount of manpower required to implement the things that you guys have done to achieve what you have done. There's a cost associated with that. And my question is, do you guys have a sense for, number one, what the cost of the manpower is that you guys have had to do for the joint camp, the MAs, the health partnership that you established, overall, what that is on a yearly basis, just to give us all a sense for what we're looking at in the future.
You notice that we use the term investment.
Oh, I know.
We like investment.
Well, we all sat, that was the thing. We didn't want to start doing this unless we could get somebody to invest into the program before starting it. Because what we said is, I bet you we could keep doing status quo and we'd waver around our target price, historical average. Oh, if status quo, we risk losing money. If we invest in doing the things that we know as clinicians are best practice improvements, we're likely to save money. And what we're seeing, if you extrapolate this for an annual return from CMS, we might be around $1 million back from CMS back to this institution. Our investment on the front side has been probably in the $180,000 range annual. So that's including TAF health, MAs, a case manager, a nurse. Over what?
That'd be over 2 years.
Over 2 years, yeah. So we're at 20% investment on return on investment.
So the volume of that's as
And we're on the low end. If you look at that NYU example,
Yeah, they hired
6 care coordinators, almost a dozen increase in MA, RN type people. I mean, so part of that was built into the package of the guy who was going to come in and lead the program. He said, this is what we need, and it's expensive. And there's no doubt. So you need, kind of visionary leadership to be able to say there will be a reasonable return on investment. Steve?
Chris, I'm assuming that the patient selection comes into play with this, with the sicker the patient, probably the more cost down the road with the aftercare. Do you see a problem with, if everyone starts getting to bundle payments, that it becomes like a Medicare thing again, where the university starts taking care of all the sick people?
So that's the other thing that CGR is going to force. So in addition to the fact that they're going to probably create regional centers of excellence by the default of winners and losers, there's going to be a lot of risk aversion or diversion type of practices going on, because they know that the more costly patient they're going to probably lose on. And so the docs and the hospital administrators are going to say, oh, we're not going to do them on those types of patients. We don't really have that luxury at the university because there's nowhere else we can send patients. And so once they're here, we do them. We try to optimize them as much as possible. Preoperative optimization is part of this. But in some way or another, it's either, if this patient is indicated for the surgery and there's no other option, we wind up dealing with it. But yeah, it's going to create a problem with risk diversion.
And you see, just as you see, surgery center creation, cherry picking, healthy, commercially insured patients, we're going to see this within the Medicare population as well. I'm not sure there's a way around it. Chris?
So Chris, obviously this is important from a financial standpoint, but probably most important is really the quality to the patient. So you've actually seen a decrease in the complication rate for the patient, which is probably one of the important things, patient outcome in all this. Have you seen changes in your patient satisfaction over time with the tab too? Because I would just think the feel of being reached out to by the patient would be reflected in your patient satisfaction scores.
Yeah, absolutely. I mean, I think I was trying to allude to that, but it's, you know, those other systems that were sort of app-based systems where you had to ask the patient to do more. I mean, we've seen the absolute opposite. We've had patients sending us comments or letters saying, I can't believe the amount of outreach you guys have done. I felt like I was cared for in a way that I've never experienced in a healthcare system. And I think it really makes them feel like, you know, they're cared for. And so we've definitely seen that not only is our quality improved, but our patient satisfaction is better.
And then I just have one more question. So you're 3 different practitioners with, everybody has different sort of beliefs in how things should be done and what's best practice and that sort of thing. How did you guys manage that? Sort of trying to standardize care between 3 people and, you know, 3 intellectual egos and 3 different levels of experience and
Yeah, it's a good question because we've had difficulty with that in the past. And I mean, I think we all just kind of buy in that this is the right way to take care of patients. There's been, I mean, there's some individual variation, but for the things that matter, I think we all, you know, pretty much come to an agreement that that's the best way to take care of patients. And so individually you give up a little bit, but the team benefits from the whole. Is that fair?
Yeah, we meet quarterly to try to come together on questions or topics that are outstanding, as opposed to trying to send an email and have everybody kind of come to a consensus. We now sit in the Eichel's conference room with USC with our entire joint team, and the nurses often will have a concern, or we have a concern, or whatever it is, and then we all just kind of come to a consensus. There's still nuanced things that we do in our day-to-day practices that are different between each other, but it's the broader care pathway that we come to consensus on, I guess.
And they include their MAs on that, I mean, everybody, which is a fantastic thing.
Dr. Burks, we apologize for the use of the word value today.
About to throw up in my mouth.
I guess one question is, sitting in conference, I hear about anterior and posterior approach to the hip and dislocation rate. I hear about metal on metal. I hear about a total knee that's total cruciate sparing versus not. So in this model, it seems that the best way to go is to take the cheapest, most effective implant and approach and hammer it out. And so how do you look at it as an academic guy to say, well, we may want to try a new material, we may want to try a new approach, this new implant looks sexy. How do you fit that into your program?
Yeah, that's a really good question. And I think, you know, what you're seeing across the country is that this model is definitely driving kind of the use of lower cost implants, for sure. The influence of the approach is probably less important because now, you know, there's not huge differences in terms of time or complication rates between anterior and posterior approaches. So I think that kind of falls out. But where it really becomes true is implant cost. And there are a number of centers across the country that are really pushing hard to drive that down as low as possible. But,
Including NYU.
Including NYU. But when you look at it in terms of the big picture, like right now, I'll just give you a rough number. We pay at this institution about $3,500 for a total knee implant. At Mayo Clinic, that's sub $2,000. So doing the exact same thing, they're saving another $1,500 per case. So the pressure will be to continue to drive that cost downward. And traditional implant manufacturers are going to continue to feel the pressure. And for that reason, you're starting to see a number of smaller startup implant companies begin to offer lower cost implants that hopefully will have the same quality, but the bottom line is we don't really know.
And we're insulated right now by the 90 days. So when we showed the drafts, we're saving $12,000 by not sending someone to a SNF, or $35,000 by not sending someone to rehab. And so right now, our savings is on our historical average of using those at a higher rate. So we're benefiting from that, and the small cost differences in maybe an implant or an approach are being insulated by that. So in the future, when we get to this race to the bottom and we've kind of cut the fat out of everything that we can cut it off of, that's probably the next level of stuff that we're going to have to be forced to make decisions on whether we think as an academic institution we need to drive down that another $500 to save just a few more pennies here or there.
And I would add on that cost, that the added expense we've incurred from the care navigation, we're already looking at that. And in fact, Jill's been working really hard with Healthy Plan to try and bring this in-house, even the tab that we call it, we're looking at bringing in-house, and we'll potentially cut that cost in half. So,
Well, I mean, total joints, you know, are those things that have a long life expectancy to them. So you can cut a lot out in 90 days, but you may be backfilling in 5 years because the new implant, the cheaper implant, the something is requiring more revision, or there are other circumstances down the road that weren't foreseen. And everything looked great to start, but now we're paying it back and stuff.
10-year bundle would just be a 5-year bundle.
A 5-year bundle, yeah.
We're a little bit warranty.
We're a little bit over. Well, thank you all for your attention.